So good morning. Thank you very much for watching the part 1 series of the contraception method, best contraception methods. So as I had promised, today we're going to tackle permanent sterilization in both male and female. So sterilization is basically what we commonly refer to as bilateral tubal ligation in females and vasectomy in males. These are permanent methods. If I can start by tackling bilateral tubal ligation. So this is whereby a woman's tubes are destroyed completely. So there are different ways in which it can be done, and as I said, this is still in the first tier of contraception. Very efficient if properly done, close to 99.5% efficiency. So the different methods in which bilateral tubal ligation in a woman can be done. So number one is electrocoagulation, whereby we open up and before I even get into the methods, just know that it can be done either as an interval surgery. So once you decide you want to do a tubal ligation, you can go ahead and get it done, preferably laparoscopic. And laparoscopy is getting very much advanced in Kenya. We have been doing it where I work. And I think I'm proud to say that I was in the first team that started the rotation of laparoscopic surgery. So laparoscopic surgery is basically a keyhole surgery, whereby you wake up and you have no wound. It's just like a centimeter or so at the umbilicus, so which will not see. So it can be done laparoscopically, or if not laparoscopy, if your town or your hospital does not have laparoscopy services, then it can also be done through what we call a mini lap surgery, whereby you have like a 2-centimeter wound at near the navel, below the navel, so near the pubic area. That's where, and then we're able to do it from there. So you don't need to be pregnant or to undergo a C-section for you to get tubal ligation done. The second, it can also be done after or during cesarean section. So once the baby is removed and the abdomen is wide open, so once they tie the uterine womb, then they can also tie the tubes. Then thirdly, it can also be done once you have done vaginal delivery. So once you have delivered vaginally, the uterus is usually still quite big, so it makes it very easy for the doctors to do a mini lap. Mini lap is, as I said, a 2 centimeters incision somewhere in between the navel and the pubis, or at the pubis area, depending on the size of your uterus, and then easily retract the tubes, cut them and return them, and you go home with a very small suture. Okay, so there are different methods of doing it in all these three settings. Yeah, so one of them is electrocoagulation, whereby we open up whichever way we're opening, then we use what we call electrocoagulation. So electrocoagulation is basically using electric current to burn. Yeah, so they are burned on both sides. Then it can also be done in what we call as a suture ligation, what we usually do commonly in our hospitals. Suture ligation is whereby, and there are different ways of suture ligation, whereby we cut and then we tie with a suture is a string, surgical we call it string, but what we use to suture. Yeah, and then the another one is mechanical methods, which I use, like for example, slipping in rings that can be used to occlude or clip the tubes. Okay, so but what we do in Kenya mostly is the coagulation and the suture ligation. And nowadays, and I think also in the hospital where I'm currently based in, we do what we call total salpingectomy. So we will not just cut a portion of the tubes, the fallopian tubes. So what we do is that we cut the entire tube. So from the beginning of its attachment to the uterus, and then we cut all the way to the end. So there's no going back in such a situation, right? So we cut the entire tube. And the advantages of doing this, it's the in thing right now, because it has shown significant advantages. Like for example, it will prevent you from getting ovarian cancers in the future, because it has been stipulated that, or postulated rather, that some of the ovarian cancers, especially the epithelial type, they arise from the tubes. Okay, from the end of the tubes. So once you get the entire, if you're getting rid of the tube, then get rid of it, all of it. Yeah, so that's what we have been doing. And we cut from the beginning near the uterus attachment all the way to the end, what we call the femoral end. So total salpingectomy, it has its own advantages in that the failure rate is practically I think it's like 100% efficient because there's no tube, there's nothing, zero. And then secondly, it prevents ovarian cancer, future ovarian cancer, especially in patients who are at risk. Okay. So, and people are asking, so why do we cut the tubes? Because as I've been talking earlier, it's that the tubes are the ones. Okay, fertilization occurs in the tubes, so that's where the ovum, that is the egg from the ovary, and the sperm meet to make a baby, right? So if you do not have a tube and there's no conduit for these two to meet, then basically there will be no baby formation. Okay. So why is it called? Why is it not termed as 100% successful? Because it has its own. It can fail, and it can fail because of different reasons. And the first reason as to why it can fail is surgical error. Okay. So if God forbid your doctor, instead of tying the tubes, ties something else like the ligaments that are usually around that place, and they can confuse you with the tubes, then yeah, if you tie the ligaments and you don't tie the tubes, then definitely you'll get pregnant. Yeah. So this accounts for close to 50% of failure from race method. Then the other thing is that sometimes it can happen that they reanastomose. So reanastomosis is whereby the tubes, so the end that is cut near the uterus attaches to the other end, so they can reanastomose. They can get together and reattach. So this can cause a failure of this method. Then again, it can also fail if you are already pregnant, especially like in the first few weeks of pregnancy, while you were going to go for the tubal ligation. So if you're going to get the tubes tied and you already have a baby growing in the uterus, then of course you will still carry on your pregnancy. Okay, so then I forgot to mention that in some settings they normally do what you call Eshua or other blockages whereby you don't need to open up. They slide like rings through the cervix and then they direct them laparoscopically to the tubes. Laparoscopy is where you use camera and vision to see, right? So when they slid it into, but it's not available in Kenya. I do not know of any facility that is doing it. So let's stick to what we know in Kenya: electrocoagulation and tying the tubes using sutures through the different methods. So what are the things to consider as you go for this permanent method? Because it's really permanent. It's because once the tubes are cut, the chances of it reanastomosing is 0.00 something, or it's almost impossible. Okay, so the things that you need to consider when you're going for tubal ligation as a method of family planning: that one, it's permanent. It's considered permanent. It's more permanent than anything else. Okay, so you need to be sober. It has to be a very sober decision. This is not a decision that I will advise women to make on the delivery bed, because you could be making that decision based on emotions, based on the pain of labor, or maybe a heartbreak. Maybe you broke up with the person who made you pregnant, and here you are. It's not a decision to be made emotionally. You have to be extremely sober, because you have to know that this is a permanent method. There's no going back. And I've seen quite a number of patients who come in and they're like, I regret, I shouldn't have gone through that, and I want to get a baby, so what do I do? So the only way out is in vitro fertilization, which is very expensive. I think in Kenya it's close to 450 to 600,000, and doesn't have 100% success rate. It has its own. It's like what I think in Kenya it's like 50 to 60% successful. So why would you want to go through all that because you made a decision emotionally? Yeah. So, and then the other issue is that you need to also consider your family size. Like if you have like I've seen people who are like 27 years old and they have like 10, 11 children, then those ones maybe we could consider. Yeah? Yes, 26-year-old with 10 children, it can happen. So it's good to also consider your family size before you make this decision. Another thing is that as much as it's a female, because as a female, as an 18-year-old, as an adult, you do not need anybody's permission to do what you want with your body. So you do not really need your husband to consent for it, but it's always good to discuss with your partner, with your spouse, about undergoing this method. Then, yeah, and also consider your age, because if you're like 20 years old or 23 years old, even if you have 3 children, there's so much ahead of reproductive life for you. So it's not a decision to be made so early, at such an early age, because, people lose spouses, people lose children, God forbid. People move on and get divorced from their spouses and move on to other partners and who you probably want to have children with. So I think your age also matters a lot, because if, for example, you are like what, a 39-year-old or a 44-year-old, and you just don't want any hormonal methods in your system, and you're done with family, with giving birth, and you just want a method that will just not have any side effects and push you to your menopausal ages, then okay, then you can go ahead and get it done. But if you're a 23-year-old, 22-year-old, I wouldn't recommend it. I have personally declined to do such cases, made out of emotion. Sometimes somebody comes at 22, 23, 24 years old, they're crying, and then they decide that they'd signed the dotted line. So I think it's a decision that I always involve my bosses, because you don't want to do something for a patient and then they end up regret for the rest of their lives. Yeah, so I always have to counsel and make sure that they really, really know what they're getting into. And if they feel like they're emotionally disturbed, then I will mostly involve my immediate senior and tell them that, I'm supposed to do the surgery. I do not agree with the reasoning for doing it.